Welcome back, everyone, to Mastering Oral Pathology. I am so excited to have you here today. As dental students and future clinicians, you're essentially on the front lines as diagnostic detectives. So today, we are diving deep into a truly notorious mucosal condition. It's a classic, high-yield board topic, and honestly, a wildly dramatic clinical presentation. We're talking about erythema multiforme.
So put yourself right in the clinic for a second. Picture this. Your next patient sits in the chair. They are super apprehensive, in a ton of pain, and they've got this explosive onset of bloody, crusting ulcers all over their lips. And then you happen to notice these distinct target-like spots on their hands. Do you know what you're looking at? Because I can tell you right now, this isn't just your everyday aphthous ulcer. You really need to act fast, and you've got to understand exactly what is happening systemically. To get you completely board ready and clinically confident, here is our roadmap for today's session. Etiology and pathogenesis, clinical features, histopathology and immunopathology, differential diagnosis, and we'll wrap up with treatment and prognosis. Let's jump right into Section 1, Etiology and Pathogenesis, uncovering the triggers. Okay, so what exactly is erythema multiforme, or EM? Fundamentally, it's an acute, self-limiting hypersensitivity reaction. It's characterized by those classic target skin lesions, ulcerative oral lesions, or, very often, a mix of both. And this perfectly highlights the core pathology. This whole thing is widely suspected to be driven by an immune complex vasculitis. Basically, antigen-antibody complexes are forming and then actively targeting the small blood vessels in the skin and the mucosa. Now, what's really fascinating here is the dichotomy of the triggers. In about half of all EM cases, we can actually track down a precipitating factor. And they almost always fall into one of two camps: infections or drugs. The absolute heavyweight champion of infectious triggers is the herpes simplex virus, types 1 and 2. Get this. In recurrent idiopathic forms of EM, HSV DNA can be detected in a staggering 50% of cases. Then, on the drug side, the usual culprits are things like barbiturates, sulfonamides, and anti-seizure meds like carbamazepine and phenytoin. You're probably wondering, how on earth do totally unrelated drugs cause the exact same mucosal explosion? It's kind of wild, but it comes down to molecular architecture. These pharmacologically unrelated drugs just happen to share similar protein folds, which ends up exposing regions that look identical to an already angry immune system. Moving on to Section 2, Clinical Features, the clinical crime scene. Listen, if there's one single sentence you need to burn into your memory for the boards, it is this exact description of the classic cutaneous lesion of EM. Concentric erythematous rings separated by rings of near normal color. Those are your famous target or iris lesions. You'll typically find them in a symmetric distribution, mostly on the extremities. And, fun fact, the name erythema multiforme was chosen because the skin manifestations can take multiple forms: macules, papules, vesicles, bulli. But that target lesion, that's your smoking gun. Intraorally, EM is characteristically an ulcerative disease. The absolute hallmark is this exquisite, bloody, crusting ulceration right at the vermilion border of the lips. The disease can range from just a few aphthous-like spots to widespread superficial ulcers covering the lips, buccal mucosa, palate, and tongue. But here is a massive clinical pearl for you. The gingiva is usually spared. Seriously, if the gingiva is heavily involved, you need to hit the brakes and rethink your diagnosis. Demographically, we are usually looking at young adults. And interestingly, the recurrent cases often flare up specifically in the spring or the fall. When we talk about disease severity, we basically divide erythema multiforme into two main spectrums: minor and major. EM minor is your classic milder form. It's usually triggered by HSV and stays confined to the skin and oral mucosa. EM major, which historically was referred to in its severe form as Stevens-Johnson syndrome, is a totally different beast. This one is highly associated with medications, especially analgesics like oxycamps. The severity is intense. We're talking widespread involvement of the mouth, skin, genitalia, and critically, the eyes. Conjunctivitis and uveitis in EM major can lead to severe scarring and permanent blindness. Let's shift gears to Section 3. Histopathology and immunopathology, the microscopic evidence. If you take a biopsy, the microscopic pattern can vary, but it consistently tells a story of tissue destruction. Let's walk through the layers. Up in the epithelium, you're going to see hyperplasia, spongiosis, and eventually necrosis. Pay really close attention to the basal layer, because that's where you'll find apoptotic keratinocytes, cells that are essentially programmed to die. right at the interface between the epithelium and the connective tissue, vesicles begin to form. And finally, down in the connective tissue, you'll see the infantry, heavy infiltrates of lymphocytes and macrophages, gathering tightly around the perivascular spaces. The direct immunofluorescence testing is super interesting here too. Overall, the pattern in the epithelium is pretty nonspecific. You get negative staining for immunoglobulins. But check out the blood vessels. They test positive for IgM, complement, and fibrin deposits in their walls. This is the exact piece of evidence that supports the theory that EM is an immune complex vasculitis. Plus, autoantibodies to desmopleckins 1 and 2 have been identified in a subset of EM major patients, which really hints that both cellular and humoral immunity are teaming up in this pathogenesis.
Section 4. Differential diagnosis. The lineup of mimics.
So if your patient has those classic target skin lesions, your diagnosis is fairly straightforward. But what if they only have oral ulcers? You've got to mentally line up the mimics. We're talking primary herpes simplex, severe aphthous ulcers, pemphigus vulgaris, mucous membrane pemphigoid, and erosive lichen planus. The lack of a systemic prodrome, the favored locations, the sheer size of the ulcers, and any recent history of a new drug or a cold sore, these are your major clues to pivot toward EM.
Now, distinguishing EM from its most confusing mimic, which ironically is also its most common trigger, primary herpes simplex, is absolutely crucial. Honestly, this comparison right here is pure board prep gold. EM typically strikes young adults, it presents with large ulcers, potential target skin lesions, and you manage it symptomatically or at steroids. Primary HSV, on the other hand, is mostly a childhood infection. It presents with smaller ulcers, standard non-target skin lesions, and is directly treated with antivirals like acyclovir. Make sure you keep this contrast sharp in your mind.
Finally, Section 5, Treatment and Prognosis, Neutralizing the Threat. Think of EM management as a strict escalation of care based on severity. For EM minor, step 1 is often just symptomatic relief. Keep the mouth clean with bland rinses, ensure they are getting adequate fluid intake, and use antipyretics. For EM major, step 2 involves escalating to topical corticosteroids, often paired with antifungals, just to control the severe local disease. I do have to note, using systemic corticosteroids is still highly controversial here, and some experts believe they're straight up contraindicated, especially for maintenance. Then we have step 3, which is preventative. If the EM is recurrent and you know it's triggered by HSV, putting the patient on prophylactic acyclovir at 400 to 600 milligrams daily might actually stop the cycle before it even starts. As we close out this session, I want to leave you with a bit of a provocative thought. If a young adult sits in your chair with explosive, bloody lip crusting that seems to happen like clockwork every single spring, how quickly are you going to investigate their viral history before you just automatically reach for the steroid prescription pad? Remember, treating the symptom is good, but treating the underlying trigger, that is how you truly master oral pathology. Keep your eyes sharp, keep those diagnostic differentials wide open, and thanks so much for joining me today. Keep up the great work in the clinic.